the topics that we're going to cover, we're going to first of all talk a little bit about what we think population health management is, and a little bit about the upsides that we see within PHM approaches. We're going to move on to talk about what we think it isn't, and what we think the downsides of PHM might be. We're then going to talk a little bit about the challenges that we've seen in terms of adopting population health management approaches, particularly drawing on our experience from the Midlands Academy. And then we'll conclude by offering a few reflections, a few recommendations as to what next. I'm going to ask Lucy and Gareth to introduce themselves in turn, so you get a sense as to who is talking to you today. So Lucy, do you want to go first?
Yeah, thanks, Fraser. Hello, everyone. I'm Lucy. I'm a senior consultant at the strategy unit, and just over 6 months ago, we concluded a population health management development programme in the Midlands, which I was the programme manager of. I'm particularly interested in this topic as a geographer by background, which lots of people often say geography and health, how do they link? But there's all sorts of fascinating links, particularly around kind of how we organise services based on population need and things like that, and was particularly interested when I was asked whether or not I'd be interested in the programme to support that from that angle. So that's kind of where I'm coming from today, and that's the link that I have to this topic.
Great. Gareth, don't let me fall too much into chairing. You know I've got this tendency to organise. So why don't you come off mute and then introduce yourself?
Yeah, that would help, wouldn't it? Yeah, you do it so well, Fraser, that's the thing. So yeah, just by way of introduction, so my name's Gareth. I'm a programme consultant at the strategy unit, but also my substantive role is actually as the Associate Director for Public Health England's Local Knowledge and Intelligence Service in the West Mids. So obviously I've got a sort of very traditional sort of academic analytical background in public health and epidemiology, but in terms of my sort of practical involvement around PHM, I was involved in the design and the delivery of the analyst development programme that formed a core part of the Population Health Management Academy in the Midlands. My team also undertook a large-scale skills mapping exercise around population health intelligence across the Midlands to try and better understand the capability and the capacity of the underlying analytical community to support PHM. And my role at the strategy unit at the moment is very much focused around working on the establishment of what we're calling a regional decision support centre, and the development of a network of decision support units across the Midlands. And these are all aimed and focused at enhancing the provision of strategic intelligence to improve system-wide decision making across health and care. So yeah, and I'll tend to focus on the sort of more analytical aspects of PHM in terms of what I talk about.
No, that's brilliant. I mean, that's already one of the themes I think that will appear in our conversation. It's certainly something I'll want to explore, is the role of the analyst in all of this, and the link through to decision making. Again, I think that's a really important theme that I'd certainly like to talk about. For myself, I mean, I'm by background a researcher and evaluator. Spent 20-something years doing research and evaluation across all areas of public policy, actually. So crime, drugs, neighbourhood renewal, public health, healthcare, social care, all sorts of things, which I guess, and again, I'll want to pick this up, has been really helpful in approaching the topic of population health management, because I think it needs that multiple set of different perspectives on challenges. And I directed the programme that Lucy and Gareth referred to from the strategy unit, and brought together the different partners that were involved in delivering it. So that's who you've got. I mean, to get into the substance of the conversation then, the first thing that we should talk about is what this thing is. So what we understand when we use this term population health management. It's a shame, but I don't think it's obvious. And I don't think when people use the label, everyone has got the same frame of reference in their heads. And also, what do we think the upsides of it are? So again, I'm now going to stop organising us in this conversation. Let's just go.
Shall I'll dive in.
One of you.
I was being polite.
So this is something we spent quite a lot of time doing. I think when we started the programme was actually travelling around the Midlands trying to understand the different definitions or what people understood by population health management. And I think, as Fraser had said, that actually there was quite a lot of sort of nuances. Probably not like everyone sort of had a clear understanding of what the core thing was, but then different nuances. I think in terms of the definition that we settled on, what we're talking about is data-driven decision making, thinking about populations and not pathways. So thinking about, we focus with the teams that we were working with, we asked them to pick a population group whose lives they wanted to improve. So thinking about a whole group, so such as people living with type 2 diabetes, or people living in said geographical area, kind of. So actually picking a population group, and then actually using the data to understand their needs, but also so using the sort of quantitative data, but also an emphasis on the qualitative and intelligence from evidence as well. So we sort of focused on that triangulation of data, and then proactive preventative planning and working with those people to deliver, to plan services strategically. That's it. So that sort of in its nature involves system working. It involves multidisciplinary team. It's not just an analyst job, but it's a whole system approach to planning the way we deliver services, and also I think actively engaging the people that we're working with as well.
I'm going to be mildly controversial at this point. From a sort of amongst the public health community, I think my view of PHM is that it was actually seen as almost a bit of a reinvention of public health. And I think that the view amongst the public health colleagues is it's seen as a bit of the sort of emperor's new clothes in terms of actually what PHM is. So, I mean, from a public health perspective, we've always had a focus on populations, using data and intelligence to inform decision making and action, putting in place interventions and evaluating the impact of them. So for me, it was not necessarily anything sort of new. I think it just presented a bit of an opportunity in terms of working at more of a system level, where we could potentially have sort of more potential impact on those wider population health outcomes. And again, from an analytical perspective, I think it really provides a renewed focus on the key contribution that analysts and intelligence colleagues can bring to this discussion and debate in terms of improving population health outcomes. And I think for me, it really presents an opportunity for analysts to take sort of centre stage in terms of what they do. I think maybe it's been seen as a bit of a sort of back office function in the past. Maybe there's been a bit too much emphasis on performance management or sort of routine monitoring. I think it gets us to focus on the really key sort of analytical questions in terms of being able to provide robust strategic intelligence, as I said, to improve population health outcomes ultimately across that wider health and care system.
That's great. I'm going to get you to say, but now you're feeling controversial, Gareth. I'm going to mine that scene a little bit more. I had several illuminating moments last year directing the programme. One of the most illuminating of which was a session that you were in, where we did a session for trainee public health consultants, I think. And I remember standing there explaining to them what this thing called population health management was. And in a strong field, that was one of the moments where I felt most fraudulent in professional life. You're standing there and you're going, it's about focusing on populations. It's about using data to make decisions. And the look on their faces was a bit like, is there an alternative out there? Can anyone think of an alternative way of doing things? So come on, I mean, what did the public health community really think when this stuff first landed? And do you think the public health fraternities kind of embraced this? Do you feel like now it's seeing it more as an opportunity rather than just, stop telling me to suck eggs?
Yeah, I think, like you say, I think initially there was a bit of cynicism around the whole sort of concept and the idea, but I think as things have sort of evolved, people are probably seeing it as a renewed opportunity to, have more impact and influence around things like prevention, having more of an impact on health inequalities across the broader system. So I think they've sort of come to see it more as an opportunity rather than a threat now. And like I said, to work across those wider systems, potentially they can have more influence and impact on those broader public population health outcomes, which is ultimately what we're all trying to do. I think the story sort of have changed and evolved over time a little bit. I think when it was first sort of broadcast and publicised, there was a bit of scepticism and cynicism around how it was being portrayed to them.
I mean, certainly over the year, I detected an outbreak of pragmatism from the public health community, who were seeing this as an opportunity to kind of bring more people into the fold, actually, and to help more people see the value of a public health lens on problems, of using multiple sources of data, of engaging with the citizen, of thinking in populations rather than in pathways. So I detected this outbreak of pragmatism, and when we come at the end to talk about recommendations, I mean, certainly one of mine will be to absolutely make the most out of the public health resources you've got in the system available to you. I just want to lob something out there. Isn't it sort of slightly depressing that we've had to start by trying to define this thing? And let me offer my explanation as to why we're doing it. I think it's because this thing called population health management is shrouded in jargon, this terrible, impenetrable sort of machine-like language of impactability, of segmentation, of actuarial analysis. The whole jargon around this, the whole terminology, I find utterly distancing. And that's someone who's got sort of a background in analytical work. So I should know this, and yet I find it distancing. Lucy, was that something you detected when we were doing the rounds?
Yeah, I think so. And I think possibly more so later on, I think what's one thing that's just popped into my head as you were kind of saying that is I think it's important. So I think the jargon sort of comes at population health management at the sort of system level. So I think STPs think they need to be doing population health management, and they need to do all this impactability, actuarial modelling, segmentation, which is they're all I think good things to do if done well, and helpful things, but I don't think they're the end goal. And actually, if we simplify it down to actually, like, a GP practice could be looking at their data and segmenting their population. I think Stephen did a great presentation which sort of had or was it you, Gareth? I can't remember. Well, either Stephen or Gareth did a really kind of introduction to segmentation, which actually showed that it can be as simple or as complex as you make it. And I think that's the same with population health management, is we can make it really complex, but actually at its root it can also be quite simple to do and can be done at a local level. If you take the principles of looking at the data, engaging your population, using that to make a decision. So I think it's that actually how do we then use that to make a difference and to be planning the services and changes that we're making. But I think demystifying it and that complex sort of language I think came through quite a lot. And I think I've just seen a point in the chat box about talking about population health analytics. I think also people focus very much on the analytics focus, and I think we found that as well, and you can see in that actually people think that is it, they're just doing the analytics. And I think we found on our program a lot of people there were analysts, not devaluing the analysts, we think very highly of them, but it's that how do we then turn it into something and not just get bogged down in that section.
Totally. Look, Gareth's too modest to say it. It was Gareth's presentation on population segmentation, which was by a quantum, one of the most coherent explanations I've seen of it. We should also say all the materials that we'll talk about from the work we did under the Academy, we've made freely available on a website. So if anyone Googles Midlands PHM Academy, they'll find all of the materials. So what have we said so far? We've said there's this discipline that is about improving population health and reducing inequalities, that is about using data and different sources of insight, that thinks in populations, that engages with the population, and that probably requires a multidisciplinary approach. I don't know if any of us want to talk about what we think the upsides of all of that would be then. So what are the benefits that we would claim for taking a PHM approach?
I think for me, again, it's this opportunity to focus on a whole system and to work across organisations. Again, from an analytical perspective, thinking about how public health intelligence analysts can work with their CCG business intelligence analysts, who can work in turn with their trust informatics colleagues, in an attempt to try and solve, or at least try and better answer some of those sort of system-wide, research questions and issues that people are struggling with. I think in the past we've tended to see, you know, a lot of good sort of epidemiological analysis being done in isolation, but then not sort of fully linked through a pathway or across a wider system. And I think this just presents us with, you know, a bit more of a framework and opportunity to do that a bit more effectively.
I think as well, it's also an opportunity to do that and then learn from it. It's a huge opportunity to share and to learn and to share knowledge across organisations, to somebody doing some analysis to then share that, to then interpret it and learn from it. And that just emphasis on learning from what we're doing, I think, as well, and evaluating the impact is a big opportunity it brings.
Yes, I couldn't agree more with all of that. And kind of my response to the room full of public health consultants that I was talking about earlier was a little bit like, yeah, I know there isn't a plausible alternative to using data to make decision making, but you'd be surprised what goes on. You know, it's not as though there's no improvements to be had in that area. There's a ton of improvement to be had in that area. And so for me, the positioning of analysis into a very clear process for decision making, for taking action and moving to improve population health, brilliant, absolutely all over that. The other thing, Gareth, you touched on it, but I just want to bring it out a little bit more. One of the benefits we saw from the Academy was just networking people from across systems. So, you know, we are not claiming this as a benefit of the PHM Academy, but one thing we've heard now under COVID, where analysts really are collaborating very well, I would say, is that a lot of that was kicked off under the PHM Academy, where people were turning up from the same system and saying, hello, you know, you're from just down the road. We do basically the same job, looking at the same population group. Why don't we collaborate on doing it? So that sense of better networking resources within systems, particularly analytical resources, I think was a huge upside. I'm going to move us on. Well, no doubt we'll come back to some of that. I want to talk.
I was just going to say, the only thing to that, one of the few upsides of COVID, I would say, is that it's forced, you know, some of those analytical teams to actually work together, share data, you know, collaborate. So we've definitely seen teams in the Midlands, you know, working on joint dashboards, joint outputs, which maybe they hadn't done before. So I think I'd see that as a kind of tangible, unforeseen sort of benefit of COVID that's helped to enable some of that. I think there's a good point in the chat as well. We've sort of concentrated on talking about the sort of analytics to support PHM, but then there is a bit of a leap in terms of, you know, how that gets used to inform decision making. I think it ties into some of the work that we're trying to do with the Analyst Manifesto. We're trying to raise the profile of analysts, you know, get them recognised as, you know, being able to inform decision making at a more senior level. You know, this idea and concept of a chief analyst within local systems, you know, who's at a senior enough level to be able to, you know, present and communicate the outputs of that really good analytical work that's going on.
I think there's and the flip side of that. So I think also we've talked a lot in that about analytical leadership and the need for analysts at the decision making table, as it were. But I think there's also an emphasis on, which I think we probably make less an emphasis on, but the other side of that is we need analytically literate leaders and clinicians and people from the kind of, it needs to be a two-way conversation, and actually it can't just be analysts working on in silos. And it, like, the angle we're definitely pushing on is from the analytical side, isn't it? But actually there's also the other side to actually get people wanting to look at the data who aren't analytic, who don't have an analytical background, and who perhaps have either a clinical background or a finance background or a managerial background, who actually want to engage in that conversation as well.
And remember where that went. I mean, so one thing, we entered the Midlands Academy with a sense that there was because of the analytic disciplines in PHM, we needed to do something with the analyst community. And so we did, you know, what I think was a great program, Gareth, others at the unit, this fabulous program. And it was so well received, we had to put someone on the door for the first event, because remember, people were trying, we were sort of massively oversubscribed. Through doing that work, we got a sense of a community, the analytical community, not well networked, not well developed, and not sufficiently loved, I would say. So we then did more, we extended that out. then remember we got into that work. Well, first of all, we tried to stimulate an analyst revolution. So the analyst manifesto, which I think is a really good bit of work actually, that someone else produced, we just helped with. So people should definitely check out the manifesto. Also the revolution that we tried to lead. We had good events around that. And then Lucy, as you were saying, got into running sessions for leaders that were, I can't remember what it was called, something like everything you wanted to know about analysis but were afraid to ask. So 2 or 3 sort of pilot sessions to try to bring leaders into this sort of more analytically minded way of thinking, because in a sense we kind of hit upon the sense that the decision-making process was the limiting factor in all of this. It wasn't the supply of data, it was the use of insight and analytics in decision-making that felt like margin to push on. We've kind of entered some of the territory of limitations and downsides of PHM. So can I bring us into that properly? What would we see as some of the dangers, some of the bear traps, some of the limitations, some of the downsides? Let's have 10 minutes or so on that.
I think for me, yeah, it comes back a little bit to what we discussed around, PHM being shrouded in a bit of mystery, and actually being able to strip it back to basics and do some of that demystifying that Lucy mentioned. There's a lot of sort of associated jargon and terminology associated with PHM that I think probably has been sort of misinterpreted in some ways. So I think for me it'd be stripping things back to basics. And I think the other sort of key challenge is probably a sort of cultural one in terms of that sort of joint working across systems. That's probably the biggest, sort of potential barrier at the moment. I think those would be the key ones initially for me.
I know of the two of us, I'm so much more concentrated on this, Lucy, than you are, but so I mean, I just want to echo Gareth's point about the mystification of all of this. I mean, at the high point of my cynicism on this, I think it's been deliberately mystified by consultancies who are selling solutions. So I think if you can shroud something that actually is well established, everyday, necessary, fundamentally the right thing, if you can shroud that in the language of technocracy and make it seem as though it's something other and something expert, that then allows you to create solutions to resolve the problem you've just set up. So I think I'm afraid I do observe some of that. There's a sort of related challenge and downside that I observe that I think maybe we've strayed into a little bit in our conversation, and certainly Lucy, I know you were very strong on correcting this, and I would want us to be strong on correcting it, is that you do sometimes see PHM described as though, if only we could get more data, if only we could tweak the algorithm, if only we could get more big data and AI involved, then we could find out in ever more precise detail about what this population is and needs, and then we could intervene with them more. And you set up this whole world where, you, the expert, are sitting behind your laptop, spotting these sort of passive units of intervention that we call the population, that we can just intervene with and correct. I don't know who honestly thinks of themselves like that. I mean, if for a moment, if you just consider your own life, I would like to think I and everyone else I know, has will, volition, can't be corrected by an algorithm, is actually a sort of human on the end of this, not a passive unit of intervention.
My favourite, Fraser, my favourite way of hearing that problem that you've just explained described was hearing Hilary Cottam speak. So Hilary Cottam's written the book Radical Help, and she described, we all have these we put the person at the centre, so we always have these diagrams, at least in the NHS, I don't know if other organisations have it too, where we have a picture of a person and then we have all the different services around them in a big circle. And she said it just looks like a target, like you're trying to shoot this person with all the interventions that they could possibly have. And how terrifying would that be, to kind of be the person at the centre with all this stuff coming at you? And I just thought that was quite a helpful description of I think, which I would definitely agree with what you said, is the danger that we think that more and more data will solve us the problem. We forget that actually it is a human being on the end of it, and actually somebody who has an opinion about their health and has an opinion about what matters to them. And again, a quick plug for Al's talk tomorrow, but actually he tells a great story about you might put somebody on antidepressants, but actually the reason they're feeling sad is because their dog died, so they can't get out for their daily walk anymore. Or you might give somebody hip surgery, but actually you just don't realise that they just needed a banister to help them get up and down the stairs, and actually they didn't want to be bedbound for months. And I think actually speaking to people about what matters to them, whether or not, I think this has become clear in some work that I was doing recently around COVID and decisions to whether or not to go ahead with elective procedures. Actually, big factors in that are people's circumstances. Actually, do I have a family at home? Am I going to put my family at risk if I go into hospital and have this surgery and then come home? Am I going to bring them COVID? Am I going to, and actually we sort of see it as if we see the health issue as a standalone issue, actually we neglect all of those social factors. And actually things like, does somebody have, particularly thinking about COVID, does somebody have to get on public transport to get to the place they're going to receive their care? And actually that might be scary for them, at the risk of catching COVID if they have other underlying health conditions. So I think, understanding more about the people that we're actually trying to work with and not making assumptions, I think is a danger. And we think because we've spoken to 10 people that we know what that population thinks, but actually everyone has different circumstances. And I definitely wouldn't want to be put into a bucket along with the 10 people that I've never met, kind of thing. So yeah, I think that is definitely a danger.
I'll let Gareth chip in a second, but I've got to say, I mean, I love Al Mully for a million different reasons, but one of the main reasons is that, I mean, what is he? You know, sort of clinician, economist, you know, more degrees than you care to shake a stick at, expert in so many things, and yet what's his thing? It's like, talk to people, find out what matters to them, and work with that. Gareth, I could see you were revving up.
Yeah, I mean, I was just going to say, as a sort of follow-on to that, really. And obviously with PHM, you know, there's a really sort of heavy emphasis seems to be around, you know, the use of linked data and complex algorithms, machine learning, and the rest of it. And I think, yeah, in essence, you know, whilst those linked data sets will be really valuable in terms of, you know, having them at a patient level and then being able to aggregate and do some analysis at a more aggregate population level, I think for me, again, it is triangulating that sort of hard quantitative data and intelligence alongside some of the qualitative, you know, really valuable information that Lucy talked about. And then obviously, yeah, weaving in the evidence side of things as well, in terms of, you know, what's most likely to work for that population. And then thinking about, you know, well, how do we evaluate what we've done locally? And that was one of the key gaps in terms of the population health intelligence skills mapping work we did, was around evaluation skills. And obviously, if you're putting in place local interventions and you're not able to effectively evaluate whether they're you know, working very well or not, that's quite a sort of substantial gap in terms of the system sort of knowledge. And something we're actively trying to address, I guess, as well within the work that we're doing.
And I meant to sort of shine, just, you know, underscore what you were saying. Really, I mean, that mapping work was brilliant. It's absolutely brilliant, and it led in very large part, alongside all the other work we did in the year, to the formation, or the notion of the formation of the decision support units, which we should certainly come back to at the end. There was something else that you mentioned, which was about using the evidence in designing what you might do. So one thing I've observed a lot of people describe in the sort of, you know, King's Fund type case study of PHM, they will often say, you know, we analysed the data, we got all the intelligence gathered together, then we got into a room and we just decided what we were going to do, and then we did it. And at every point I've been thinking, you know, at what point did you look? What is likely to be effective to achieve the outcomes that you were intending to achieve with that population group? It's very often skated over. But, you know, what do we know is likely to be effective or even ineffective, perhaps harmful in trying to achieve outcomes? That seems to me to be a fundamental stage in the decision-making process around that. Should we move on to challenges?
Yeah, and I'd like to pick up a point that somebody's made in the chat box, which I think is one that we definitely found true during the programme and in Gareth's skills mapping work, I think. So Jonathan has said that actually the challenge is that people are trying to balance the demands of the day-to-day versus the longer-term population health management planning. And I think just wanting to reflect that is a real challenge. And in the programme, we'd asked teams to come through and dedicate time to the project, but actually we definitely noticed that they were finding that challenging to even commit to all the sessions, let alone work outside of the sessions. And then also in Gareth's skills mapping work of the analysts, we found that actually a huge number of analysts were doing the performance reporting, sit rep data and things like that, and actually don't have as much time to start thinking strategically or to do the more creative kind of work and problem solving. So I think just wanting to acknowledge that is, yeah, definitely a real challenge. I'm not sure if I think we did come up with some solutions, which I'll let you guys talk about more probably.
Well, the solution I would offer to that is imagine a situation where there aren't urgent things to do in health and social care, and you've got plenty of time and resource to do things that you know are important. And presumably, literally no one can imagine that ever being the case. You know, it's much more realistic to assume that there will always be urgent demands and that resources will always feel highly constrained, and therefore to work out whether you really value doing this developmental work or not. And if you don't bother. But if you do, then commit to it. I mean, that would be and I think that obviously there are acts of leadership in there. One thing I'm perennially surprised by is very senior people in the system describing themselves as though they're victims of circumstance rather than someone who can exert will and make decisions. So that'd be my advice.
And again, just going back to the skills mapping work, we actually found in terms of capacity at an STP footprint level in the Midlands that, you know, there were well in excess of 100 whole-time equivalent analysts within most systems. So actually there was a fairly sizable analytical resource there. And in terms of some of the recommendations we fed back to the STPs, you know, even if you think about freeing up 5–10% of that capacity to do some of this more, you know, strategic intelligence insight work, then that would be a significant step in terms of trying to move forward. And just freeing up some of those people who maybe feel a bit constrained in terms of doing that routine monitoring, performance management work, and, you know, maybe trying to get the sort of leaders of those analytical colleagues, to think a bit more broadly as to, you know, is this the best use of their skills and capacity and time? And definitely there was a feeling amongst the analytical community that it maybe weren't being as best utilised as they could, so they were a little bit sort of frustrated, and you know, there was a general feeling that their skills weren't being fully utilised and exploited.
And you could also do what was it Stephen suggested the other day, just do it under the radar. No one's looking at what you're doing 100% of the time. just do what you want to do in the corner.
Stephen's sense of passive resistance, I liked it very much. I mean, we took a much more head-on approach, didn't we, by trying to lead the revolution, because we met so many analysts who were saying, look, you know, I'm highly skilled at this and that. I could be making more money elsewhere with my skills elsewhere in the labour market. Bored by what I'm doing. I'm producing dashboards I don't think people are using. So I agree. I also think there's something on the analyst community to say, well, look, the stuff we're doing isn't always as well used as it might be. We could be deployed onto much more interesting or strategic questions. And I think population health management gives them that opportunity. Can we talk a bit about the challenges to adopting some of this, and then we'll come on finally to talk about some of the recommendations. Lucy, you touched on something that I really wanted to pick up, which was about sort of multidisciplinary working across teams, across specialisms, across disciplines. Because one of the things I saw in the academy that I didn't expect, it completely surprised me, was that the progress that people in STP teams were able to make very largely seemed to me to be determined not by some of the apparently technical disciplines, but by the more social and relational disciplines of being able to work out how someone from a completely different professional background sees the world, understands the world, makes suggestions, and that you would combine those different types of input. Was that something I think it was something you observed, wasn't it?
Yeah, definitely. So it sounds like such an obvious answer, isn't it? And I feel always feel a bit cliched saying it, but teams that had established relationships with each other and knew each other worked much better together than teams who were getting to know each other for the first time on day one of the programme. And I think this is something that struck me recently as well, actually, our ability to, I think we're all trying to do system working, but we're still restricted by the hierarchical nature of our organisations. And I think, and somebody said to me last night, actually, that, you can't just throw away the hierarchy, which everything in my nature says that we should. You can't throw away the hierarchy. You have these structures that are in place, but it's how do we work with that to create networks between people at different levels of the organisation. And I think that is definitely one of the challenges, but actually I think a real potential in this. And I think now that we're all working from home and we're making better use of platforms and things, actually there are lots more opportunities for networking and creating those relationships, because I think that ability just to sort of be able to understand a bit of where somebody's coming from just softens your reaction to them totally, doesn't it? Actually, I think we can sometimes go into conversations if we're just always looking at it from our perspective, we can almost sort of get a bit defensive, or we're trying to fight for our corner. But actually, if we can start to enter into conversations looking to appreciate what the other person's perspective is and have a bit more of a dialogue and trying to build those relationships to work through problems together, and just take that approach and just recognizing that everyone has something to bring. And I think when we're talking about, again, that people are complex in nature, that like we're human beings are not straightforward. We don't do what we're told. And so I think you need that expertise from the clinician who's been working with a group of people, or a youth worker who has been working. Yeah, you need that to make sense of all of the data.
That's a really nice example. So your point about hierarchy, I completely take, and yet I think it's completely situationally specific. In the conversation between the clinician and the youth worker, the clinician has expertise in relation to things that are in a clinical domain. They don't have expertise over everything, and the youth worker has expertise in relation to, presumably, that young person's life, what it was like to be, et cetera, et cetera. So the best teams I observed were led by people who could recognise different situations when different types of input or hierarchy, or however you want to think about it, were most relevant, and could fold that together. That is a pretty rare set of skills, and particularly in the NHS, I think with so many people are sort of attuned to the person with the, I don't know, highest pay band or whatever, clearing their throat, and then everyone else shuts up as they make the decision. And that's just the wrong way of going about it in this situation.
Yeah, so I think it's how we create the networks within the heart. Like, how do we create that environment while recognizing that we are in a hierarchical organizational structure. So
I think just following on from one of Lucy's points around one of the other key challenges around adopting PHM is probably, I think there's probably still a bit of work to do on the clinical engagement front. And I think we probably need, to get some good sort of local clinical champions to sort of, push the approach. They do exist. I'm not sure we're sort of making best use of those at the moment. Again, it'd be useful to get a feel from the guys in the audience as to whether they think that's a particular barrier at the moment. That's probably something that I sort of see it on the ground at the moment.
I'm conscious of the need to, we've got sort of 10 minutes or so left, and here I am getting all organisy again. But I want to spend that time, as well as spotting things in the chat box, also thinking about what next, or what would we recommend given the experience that we had over the year of running the PHM Academy. I want to kick us off. I mean, recommendation number one from me would be to sort of recognise, value, develop, love, nurture, bring into the tent your analytical community. Make absolutely there's so much more value in the analyst community than we currently extract from it. That might mean, dropping some of the more humdrum stuff that we ask them to do, but I think there is so much more to be taken from the analyst community in terms of the value they can bring. So that would be, recommendation number one from me. I don't know who else wants to add.
I think just leading into that, I think if you haven't already, think about establishing and developing your local analytical networks across your different health and care organisations. So, try and bring together the analytical teams, to meet on a periodic basis. Do they all know each other in terms of what they do and what data they've got access to and what tools they utilise and what methodologies, and do they get the opportunity to sort of share and talk about system-wide analytical, big sort of strategic intelligence research questions, and hopefully that will enable to start this sort of culture of potential joint working in the future.
I think just adding on that as well, just thinking about network sort of communities of practice, or I don't really know what the term is, but actually just if you're interested, if you're trying to think, if you've got a population in mind, trying to bring together a group of people just to think about kind of, doesn't need to be fancy, it can be small, just start small and just start thinking about what different people can bring, and sort of having that idea of an analytically literate, non-analytical community, if that makes sense. So if you're not an analyst, actually thinking about who you need to bring in, and yeah, thinking as well about that clinician side of things, or just other, not just clinicians, but people just working directly with the population as well. And I think start small. I think it doesn't need to be, I know that a lot of the things that we would suggest as well are at kind of regional level, but I think also locally there are opportunities, and you don't need to wait for somebody to tell you that you can do it. I think it's actually, what can you do locally? What data have you got? Who have you got in around you? And is there something that you can do at a local level without having to ask for permission?
And that was the main principle of the core teams work within the PHM Academy, was that they formed these multidisciplinary teams to try and tackle a particular sort of population health issue that was pertinent to their STP. And I think that was just a helpful way of starting that sort of journey in terms of trying to undertake this work and not sort of biting off more than you could chew initially. So we've got some good examples, within the Midlands.
Not letting perfect be the enemy of the good in that case, just getting going with something, but knowing that whatever you did would be improvable, provisional, temporary, and just putting in systems for sharing learning as people go through. It's my sense that this is a sort of emerging discipline, and that we'll all get better at it by open and honest sharing as we go through, as well as sort of networking analysts and bringing them together, as well as cracking some of the challenges around data linkage and IG, which often I think actually are overblown, and as well as pushing on some of the technical margins around impactability or actuarial area analysis, whatever it would be. I think there's something about the position of analysts within the decision-making world and within the decision-making structure. There's almost something cultural about not having your analyst there just to supply the pie charts, but having your analyst there to help structure the question, structure the problem, get involved in seeing the decision-making process through. And our sense that there was a lot of value in that led to the idea and the formation of the decision support units. Gareth, I don't know if you want to say something about that.
Yeah, I mean, for me, it's all about this idea of a sort of data decisions journey where, like you say, I think analysts need to be involved at the sort of outset of projects in terms of formulating some of the key questions that are trying to be addressed, and then also, at that end process in terms of presenting and communicating, translating the intelligence and the insight, to those key decision makers, and being close enough to that decision making process. So I mean, that's the basic premise of what we're trying to do in terms of the decision support unit concept in the Midlands. So we're looking to establish this network of decision support units across each of the STPs within the Midlands, and get them to work in a networked fashion to share expertise and things like share analytical code, share sort of joint evidence resources and that sort of thing. And then we're also in the process of formulating a decision support centre at the heart of that network that aims to essentially be the sort of glue between those different networks. There's a bit of an emphasis there around training and development to support the wider network. There's things like active knowledge exchange that we're focusing on around, how do we best share and utilise various bits of evidence or literature reviews across that wider system. And it's all essentially aimed at enhancing the provision of strategic intelligence to improve that systematic, system-wide decision making. So it's fairly early days. We're just in the process of getting that sort of established and initiated, but it's a potential model to really help sort of mobilise the approach to PHM on a wider scale.
also for me, I mean, one of the things I felt running the Academy for the Midlands was the way that the NHSEI region and at that time the PHE region was able to show its value in convening different systems together so that we could do things at the regional scale, that we could bring people together from across different local systems. Really nice way of that level of the system, of the hierarchy, showing its value in bringing people together and convening them. And I think that's, to me, keeping that sort of thing rolling is a really good idea. Yeah, Lucy, I don't know if you got.
No, I think I'd just agree with that. And yeah, convening and bringing people together. Somebody's put in the chat box local authorities too. So yeah, just don't forget them. They are really helpful too. Yeah.
And again, that's part of my key role from my substantive role at PHE. Part of the reason why I've been sort of brought in to support the establishment of the decision support units has been to just ensure that it's not totally NHS dominated, and it is bringing in that local authority aspect, and not just across public health. You know, it's thinking about social care, thinking about some of the other wider determinants of health, and that will play a really key role in all this. So yeah, that's a key part of mine and my counterparts. The reason why we've sort of been brought in to support the programme.
I mean, that's a considerable personal charm. It was, I mean, that, you know, that for me is kind of back to the beginning of our conversation in a way. What would one of my recommendations be for people trying to advance this in their area is go and find your public health people in the local authority. They have, you know, a very, very good chunk of the analytic disciplines, a very, very good chunk of the way of thinking about these things, experience in multidisciplinary working because of being positioned in an authority, a sense of how to engage with citizens, and there's so much value there in that sort of working across disciplines. I think that's a really important part of that story. I don't know if there are any other questions in the chat box that either of you have spotted or that David you've spotted.
There's some good discussion going on. I think that
I'm not. I know, Lucy, you can do it. I can't see things in the chat box, and I'm sorry, God, what? Room for what? But is there anything in there that you think we should pick up?
I don't think so. I think there's loads of good stuff, but I think it would just, in terms of if we were trying to respond to it now, I think we'd run out of time.
And more sort of comments, either sort of agreeing or just adding their own sort of personal perspective on what we've talked about, which was essentially the sort of purpose of the session. So there's some good resources that are being signposted too. There's a Nesta Good Help guide that takes into account wider issues that affect people's health and well-being, that might be worth a look. There's also a colleague who talks about, there's more on PHM a day today via the NHS Confed conference as well. So obviously there's it's a huge topic that's being talked about extensively at the moment.
That's fantastic. That's fantastic. And certainly, so all of those resources, that sounds great. Nesta certainly do some fabulous stuff, and I'd expect the Confed to do as well. Again, just to say that all the things that we've talked about, all the resources, all the training materials, all the slides, all the webinars are on the Midlands PHM Academy website too. I'm conscious now we're coming up to time for Remembrance Day. So David, shall I sort of close our bit of the session and hand back to you?
Yep, absolutely. Just let me share this. Can you see my screen again?
Yeah.
Right. Okay. So that's it for today. I'm just giving you a quick reminder again of what's coming up this week. I'd like also to thank our presenters for giving up their time to provide us with an excellent session, and to you for joining us as well. If you would indulge me, help personalise this a little bit by turning your cameras on very briefly and just give them a bit of a round of applause, and then we can see that it's been appreciated this hour. So I'll start. It might be me on my own. I can't see the rest of the gallery, but there you go. Thank you, everyone. It's been a really great session. For now, though, goodbye, and we hope to see you soon.
Thank you very much.
Thank you.
Thank you for coming.